it will be a little, I will be try to be brief. So these are my disclosures. And when we do conduction system pacing, we try to look at and hit these areas of, main trunk, anterofascical, septalfascical, the posterofascical, and we try to be in conduction system. And that's what, whichever way we do, be it 3830 lead, be it stylet driven, we get this kind of ECGs, and we are confirmed that we have captured the bundle. So just quickly, those who are new to the system, with 3830 lead, you have to screw like this. You have to really go in a little fast, and it makes way into the septum. But when we are going for a stylet driven lead, you have to be really gentle, and this is how you proceed. Turn-wise, you have to go in. You can't be so quick, otherwise because these are sturdy catheters, and the lead is higher French, and you can go across the septum very quickly. So 7-8 turns, you just see how the notch is moving, and then the electricals, the LVAT, and the pseudo RV pattern, and then gradually you go. So I think this all has been dealt with. This is a left bundle potential which we look at, and I will be going through some of the, and this part I wanted to show. Many of the operators, they have shown their problem with slitting of stylet driven lead. This slitter has a long, metallic part, and you don't have, and there is a problem with the length of the lead, and the lead is totally lost there. So you have to start slitting when your metallic segment comes in contact with the blue part of the catheter, and then you start slitting. There will be no problem of length, which is residual length of lead, and you can easily do that. So I wanted to show this tip to everyone, those who are new to conduction system pacing. And this is the classical normal slitter for Medtronic. So this case I did, I think day for yesterday, it was so difficult. So the patient has huge RARV involvement, enlargement. And there the problem comes with you are unable to reach to the septum. You need to reach to the septum with your guide catheters, be it 315, be it CPS locator, be it Boston's system. And many times, once I was proctoring in BHU, and I had a extrathoracic puncture, and the sheath was not reaching the septum. So the first trick is you have to puncture little medially in these situations. If you feel that RARV is large, go little medially. You have extra length of sheath will in your hand. Second, you see, once we are going in, the sheath is still floating. Whichever way we go, the sheath is floating. And you see, the lead is going, just advancing. We feel that in LO and RAO, we are in position, abutting the septum, but the lead is just advancing. It means we are in free wall, and there is no contact of sheath with the septum. So what are the tricks here? One is you go medially, puncture. Second is, you have the system which is there with 3830, you can put the dilator inside, you can make a secondary bend, you can additional bend, and it has got 3 minutes of memory, and then you can try your luck there. Otherwise, you can take a CS sheath, maybe MB2 sheath, maybe a sheath from Abbott or a multipurpose sheath, and through this sheath you take the 315 or a CPS locator. So this is how you can do that. So finally, you can appreciate here, we did lot CRT in this patient, difficult anatomy. We had to do some permutation combination. I did not have to use the entire tricks here. And this was the baseline ECG, and this is how we got the left bundle pacing, followed by further fusion with CS lead. So this is how we do in difficult anatomies. This was one patient who came with 60-year-old lady with LBB with intermittent complete heart block with ejection fraction of 45%. And if you do a normal pacing, the ejection fraction can further drop. And we thought we would do you see the ECG baseline LBB with 2:1 block, rather rather complete heart block. And we had to, and this patient had a severe scoliosis of spine. So no fluoroscopic markers were useful for us. So it was all electrically driven, position of the lead, and we got this ECG. You see, that's what I was asking, or discussing in the morning. Many times you get the best of the QRS, but you may not get a good R wave or a kind of classical pseudo RBB, but it still is a conduction system pacing. And these are 5 to 10% of my cases. 80-90% of cases you get a good pseudo RBB, but in some of the patients you still get engagements LVA2 of 75-80 and left bundle potential, but you can't, in this case, this is LBB, so we did not get left bundle potential, but other criteria of CSP is there, but still you don't get a good R wave, but still, essentially, this is a connection pacing. And this was the patient which, after the device implantation, and this week published. So this was a series of lot SWOT, CRT, non-LV morphology, and finally I will end with this case. This patient came with a biphasical block with intermittent complete heart block. He had a childhood history of pulmonary tuberculosis. This was the ECG, and this was the CT scan the patient came with. The heart was in right side, and we had committed for a conduction system pacing as the patient's ejection fraction was lesser. And also we didn't want any pacing-induced cardiomyopathy in this patient. He had only one lung working, one hyperinflated lung working, and then the cardiac dysfunction, the patient will have a further problem. So you can see how bad the the course of the SVC was. It was totally shifted to right, and these were the venograms. And this was a difficult puncture indeed. From left side, you see, we had to go. And puncture was made more medially, as what I explained earlier. Whenever you want to reach there, there is a lesser length, in the entire length of the sheath can be lost once you have a dextroposed heart in the right side. And we had fixed the electrodes looking at the echo. So we knew that everything is wrong. This is not dextrocardia, this is dextroverted heart, dextroposed heart, where this shift of the heart has happened because of fibrosis of the right-sided lung. And the entire thing has been pulled up. You are not aware about anything in kind of a system. In dextrocardia, still there is a system. Dextroposed heart with fibrotic lung, you don't have a system. Which where heart has moved and gone, you never know. So we position the electrodes depending on our echo finding, where is the LV, where is the lateral border, and then we look at the LVAT. So lead positions were done with the help of echo in regards to placement of lateral leads and V1, and then we put the RA lead in the RB first, and then we took 3830 on 315. We had to do a little of work, and finally after 3-4 attempts we got a position, and this was the final kind of pictures, and these were the final parameters. So you can see here the X-ray of the patient next day. And this was the LVAT of 67, V1, V6 difference was, V1 was, RV peak time was 106, QRS was 116, we are happy with that, and this was the final ECG of the patient. We presented this in TCT this year as oral presentation. So essentially we can do pacing, conduction system pacing in almost all anatomies, be it scoliosis spine, be it dextroposed heart, be it dilated RA, RV, provided we plan things accordingly, we puncture accordingly, we make the bends accordingly and choose the right hardware. Thank you so much for the patient hearing.